A very warm welcome to all of you. So this is the second part of my lecture of post-endodontic restorations. So in the first lecture I had given a brief introduction on post-endodontic restorations, why they are required and how do you decide what kind of a post-endodontic restoration you require, whether you require only a crown, whether you require a post and core, or whether you require neither and just a normal core build-up. And I had given the indications for and the contraindications for post-endodontic restorations, that is your post and core. And I had given a brief about the treatment planning on how you decide when to give a post for anteriors and when you suggest to give the post for your teeth. And then we went on to the classification of the different types of posts. And today I will be discussing about in detail about the custom made cast post and your prefabricated fiber. Regarding the procedure on how to do it, I will be explaining it soon. So basically, because you are going to be taking an impression of the post space which you are going to prepare inside the root canal, there is definitely going to be better geometric adaptation and when compared to your prefabricated posts, because the prefabricated posts are just manufactured outside in the laboratories and they are just supplied to us for ready-made purchase. So the custom made cast post, it adapts to each individual tooth, but of course there's a lot more amount of dental expertise and hard work which is required to actually gain the impression for the custom made cast post, but of course the results are also more rewarding. So better geometric adaptation, especially when it comes to excessively flared or elliptical canals. So when you're dealing with your upper maxillary anteriors, or if you're dealing with your canines, these custom made cast posts have shown to have been showing very promising results. Another thing is that it requires only minimal amount of tooth structure removal. So the reason being that already we choose to place them in canals which are already flared. So we just barely prepare the post space just enough so that we are able to take the impression, and then as soon as the impression is taken, as soon as we have enough width for the impression to be taken, we can fabricate the post of that desired thickness. So they can be used even for extremely tapered canals, as long as the pin which you are going to be using to take the impression of the post space can fit into the canal. So probably after your root canal treatment, bare minimal amount, maybe using your piezo reamers, maybe the size 1 and the 2 can be used to minimally prepare the tooth surface. The patterns, that is your impressions for your custom made cast post, can be formed either directly in the mouth or indirectly in the laboratory. So directly in the mouth, what has to be done is that after you actually go ahead with the preparation of the post space, which I will be discussing in the later slides, you actually have to use a pin. You actually have prefabricated pins which are dedicated which are dedicated for impressions for post spaces. If you cannot find that, you can probably just use a toothpick. You can just carve it out and actually make it a very thin cylindrical piece, and then you can actually coat it with inlay wax or acrylic, or nowadays what we use is the light body impression material. So we can actually use that to record the post space preparation. Whereas when it comes to an indirect fabrication, generally what the practitioner can do is that after the post space has been prepared, he or she can actually inject the light body into the canal when the post space has been done, and at the same time load the heavy body and the putty and the light body in the impression trays and take the impression as a whole. And then of course in the laboratory, the technician will have to section out that area and actually manufacture the impression in the laboratory. So regardless whether you do it directly in the mouth or indirectly in the laboratory, multiple appointments are required, and of course you have to shell out a laboratory fee. But then and another problem is that if something goes wrong in the first visit, it can only be confirmed in probably at the end, when you're actually trying to fit the custom-made cast post in the patient's mouth, because sometimes what I've seen is that it may fit well in the laboratory on the simulated tooth, but it may not be able to fit in the patient's mouth. So a certain amount of final trimming is required on the day of the final visit, and if it's not happening, then probably you will have to repeat the tedious procedure again. But in all fairness, even though it is time consuming and requires considerable amount of skill, the results have been quite promising. The cast metal alloy, it has of course it has considerably higher amount of strength when compared to your prefabricated resin posts, and the modulus of elasticity can be 10 times higher than that of your natural dentine, because of which you can actually, it can actually create stress concentrations in the root, which is actually not so rigid as your cast post, which can result in the separation of the post and core apparatus from the root, and thus leading to here. Also, the transmission of the occlusal forces through the metal core, that is from the occlusion through the metal core onto the root, it can be concentrated at specific regions, which may lead to root fracture. So once the root is fractured, of course we all know that the prognosis is very poor, and we have no choice but to extract the tooth. And of course another major drawback of the cast metallic post is the aesthetic considerations, because it can actually cause discoloration in the gingival third, and if you are using an all ceramic crown, it is definitely going to show through. So it is contraindicated for all ceramic crown cases, because for all ceramic crowns the translucency is not going to be able to hide the underlying custom made cast post. So in those cases, we always definitely prefer to use the prefabricated posts. Regarding the prefabricated post and core systems, they are definitely much more easier. It can be fabricated and cemented in the same visit, and the laboratory is not really required. You can even do the tooth preparation for receiving the final prosthesis, that is your crown, also on the same visit. So it actually makes things a lot more easier. So they can be the prefabricated post and core systems. They are of various types. Many types were introduced in the beginning, and they can be classified according to their geometry, that is the shape and their configuration. And some of course were active posts, which actually engage into the dentine, and which could have been screwed in. So those were the prefabricated metal posts, which were active. They acted in the same principle as a screw, like when you engage a screw into wood, so you are actually having to screw it into the canal. But then studies had shown that the active posts actually create a lot of stress on the root, and because it is a metal, and because the modulus of elasticity is of dentine, the nature is such that the dentine actually expands and contracts. So micro cracks tend to propagate, and they actually weaken the root from within. Also, when you're going to be using an active post, the principle which is used is you introduce a very slightly wider post when compared to the canal space, so that you actually get the perfect fit, because the dentine, because of its modulus of elasticity, it actually expands to accommodate the post. Because of which the root is under a lot of stress and tension. So the chances of failure or fractures of these roots were very high, which is why nowadays we have all shifted to the passive prefabricated posts. We no longer use or encourage the active posts. So these are the various designs which were available. We had the tapered, we have the serrated and tapered, we had the threaded posts, the parallel posts, the parallel and serrated, and the parallel and threaded. So what we prefer is now the parallel and tapered. So it is parallel for more than 2/3 of the length of the post, and just at the apical 1/3 of the post, it is actually tapered to conform to the anatomy of the root canal on a natural. So it is nothing but just a mimic of the natural anatomy of your root canal. So like I said, the active posts create high stress which can lead to root fracture, and the parallel sided serrated posts, they are the most retentive of the prefabricated posts, and the least retentive of course is going to be the smooth sided tapered posts. So the smooth sided tapered posts of course require a luting agent. So there are different kinds of luting agents or cements which are available, which can actually lute the post into the canal, and I will be discussing about, I will be mentioning those cements in the later slides. So regarding the core, so once the post has been cemented or engaged actively into the canal, the job is not over, because now the reason why we are placing a post is to actually fabricate a core on top so that we can restore the tooth with a suitable prosthesis. The core material, of course, it should be something which is quite strong. It can, withstand occlusal forces. It should have high compressional strength. It should not, it should be stable. It should not deform easily. It should be easy to mix, easy to use, and it should have a preferably short setting time. So composites are the material of choice right now, but in the earlier days people have actually used amalgam, and they have used glass ionomer also. Glass ionomer is actually not too bad, so it comes into a close second after your composite resins in today's world. Now regarding the luting agents which can be used to cement your dowel or your post. So another name for your post is also the dowel. So the different types of cements are the zinc phosphate, the glass ionomer, the resin modified glass ionomer, and the pure resin cements. So nowadays because we are more into aesthetics, we prefer to use the resin modified glass ionomer or your resin cements. So if you are using your prefabricated zirconia posts, or you're using your glass posts, or the normal resin posts, we prefer to use the resin modified glass ionomer, or we prefer to use the resin cements. If these turn out to be a little too expensive for the patient's choice, then the next best is your normal type 1 GIC, your glass ionomer. So how exactly are you supposed to prepare the tooth for your to receive the post and core? So in this figure you can see that the tooth has been it was fractured or badly broken down. So if once the root canal has been done, after that you have to prepare the tooth to receive a suitable post. So to receive the suitable post, there were two common methods. The first is using a warm endodontic plugger. So a plugger is a hand instrument which was actually used, the primary function of which is to condense your gutta percha so that you can get a nice flat layer of GP inside the canal. So you can also use these warm endodontic pluggers to remove the GP after because of the heat of the plugger when it is subject to heat. So GP, of course, in the presence of heat, it actually melts and becomes fluidic and plastic, because of which it can be removed. The only drawback I see when you are using your warm endodontic plugger is that sometimes if you have excessively heated up the plugger, you may tend to remove more than necessary amount of gutta percha, because it can actually get pulled, and you might lose out more than you actually want to. So because of which nowadays everybody prefers to use the rotary instruments. Of course in the beginning we had the piezo reamers. We have them numbers from 1 to 6. They are also coded from 1 to 6 based on the diameter, the tip diameter. And we no longer use the Gates Glidden for the post space preparation. They used to be used at one point of time, but then the piezo reamers have captured the market because they make more sense. And nowadays, along with your prefabricated post systems, you actually get dedicated post drills. So you can actually use the dedicated post drills itself if you do not have your piezo reamers to prepare the post space, because each dedicated post drill would have come with its corresponding posts. So if you use a size 1 dedicated drill, you can use the size 1 post, and so on and so forth. So how do you decide how much is the appropriate length of the post? Very easy ways, two very easy criteria for you guys to remember is one, is that 2/3 the length of the root should be the post length. So that is one way of calculating, and the second is the amount of apical seal which you leave behind. So generally we prefer to leave 5 mm of apical guttapercha as your seal. The reason being that 97% or 98% of your canal complexities, that is your fins, deltas, accessory and lateral canals, are all located in the apical 1/3 of the root canal. So we do not want to expose them when we are preparing the post space, because as we all know, the post as itself is not antibacterial, so it cannot prevent another infection or another bacterial attack, because of which we want to leave the guttapercha and of course the root canal sealer in place. And if you are not able to give 5 mm of apical guttapercha, maybe for the reason that the root length is very less, so if you have to actually compromise on the 5 mm of the apical seal, then the absolute minimum is 3 millimeters. So that has to be removed. And yeah, so this is the warm plugger method. So you have to select a plugger which is not too large that it actually binds against the canal walls, and it should be large enough to actually hold the heat well and be able to remove the guttapercha to the level where you want it to. So you actually mark the level after you calculate the working length. You subtract 5 mm, mark this level, you transfer this marking onto the stopper on the plugger, heat the appropriate amount, and then you introduce it into the canal, and you kind of use a shearing action to remove the guttapercha, and that is how you actually create your post space in that area. So in using the endodontic plugger, you are actually not sacrificing your healthy dentine, so that is one advantage. Whereas when you use your drills, that is your piezo reamers, or you use your dedicated post drills, you are actually removing shavings of dentine around the guttapercha as well. So your canal becomes considerably wider. Okay, so that, and now certain guidelines which you can use when you are using your rotary instruments. You start off with a slightly an instrument which is just slightly narrower than the canal, and always make sure that your instrument is engaging the guttapercha and not the root canal dentine, because you do not want to perforate. Always use it in slow speed. Traditionally we have been taught that we use the piezo reamers and the drills in the speed range of 800 to 1200 rpm, and not more than that, so that you don't actually perforate the root canal and complicate matters. We can use the drills in a reverse mode, because we all know that the reverse mode is actually used to actually remove something or from the canal. Even if you use it in the forward motion, it's not too bad. It will still end up removing the guttapercha, as long as the drills are engaging the GP and not the dentine. And yeah, so if you are using your rotary instruments, that is your piezo reamers or your dedicated drills, please keep in mind that we do not want to perform the canal, the post space preparation in the canal immediately after obturation, because we do not want to disturb the apical seal unless you are using light cured root canal sealers. So there are certain light cure root canal sealers which are available. They are resin based root canal sealers, and they set immediately in the presence of light, very similar to the concept of composite resins. So in those cases, maybe you can actually do the post space preparation on the same day of the obturation. Otherwise, we prefer to leave the canal untouched for a span of 3 to 7 days. So regarding the enlargement of the canal, as you can see in the figure, you significantly enlarge the size of the canal. You get a uniform taper, and you get a funnel shaped preparation. You basically remove the undercuts when you are using your drills, and of course if you get the dedicated drills, you actually prepare the size of the canal according to the size of the post. And of course you have to use the help of radiographs to verify whether your post space is clean, whether there are remnants of root canal sealer, and whether the apical seal has been maintained flat. The reason why we keep it as a flat apical seal is because it is said to uniformly dissipate the stresses which are transmitted from the occlusion onto the post. So a flat apical seal actually helps to uniformly dissipate forces. That is what research has shown. So that is why we always prefer to have a flat seal as opposed to an uneven apical seal. Okay. And so if you want, if you are not familiar with how to use the rotary instruments, you can actually start off with a number 1 piezo reamer, which is a very thin drill. And once you have actually prepared the space using the number 1 drill, then probably you can shift over to the dedicated twist drills which come with the post and core system. If you feel that the twist drill is actually too large for your convenience and you're not confident about it. So the number 1 piezo is significantly easier to use, so you can do that. You should always be careful that you do not remove too much amount of root structure, because you are actually weakening the tooth. Please try and understand that the post and core does not strengthen the tooth in any way. It is only aiding in retention of your prosthesis. So when you are doing suggesting a post and core to a patient, please keep in mind that you are actually weakening the tooth from within also. So you have to understand, you have to analyze whether this tooth, even despite the fact that it is going to be weakened from inside, will it be able to be sustained in the oral cavity or not when it is subject to masticatory forces. That is how you actually have to decide whether the patient requires a post and the ferrule effect. It is very important. It is a circumferential band of metal which engages the tooth structure, and it is a component, a part of your post and core preparation. So if you can see the figure A, you can see that the red colored region is your post and the core on top. So you can see that the core is actually sitting on a significantly higher up on the dentine of the tooth structure. It is not exactly sitting at the margin of your crown prep. So by crown prep I mean the tooth preparation which you do to receive your crown. So if you see the second figure, you will see that the crown margin, that is the margins of your crown and the margin for your post and core are at the same level. So basically if you are actually able to prepare the tooth in such a way that you get at least 2 mm of height of the dentine to actually seat your core, and then you prepare the tooth for your crown 2 mm apical to the ferrule, you will see that the retention of your post and core is significantly increased. So it really aids retention of the post and core. So what are the ideal requirements of a ferrule? A minimum of 2 mm of the axial dentinal wall height. Of course, this is not possible in all cases. So what we do is we tend to give the ferrule on whichever surface is possible. So sometimes we will see that the tooth is broken in such a way that palatally it is approximating the cemento-enamel junction. So even after crown lengthening, if you are not able to get healthy amount of tooth structure, we ignore making a separate ferrule for the core on the palatal side, but we prepare the ferrule on the labial and the proximal sides. So a little ferrule is better than no ferrule at all, is what I am trying to say. And we have to try to keep the walls of the ferrule as parallel as possible, and this helps in actually encircling the tooth with the help of the core. So the core can either be your metal in the case of cast posts, or it can be your prefabricated post as well. And of course the ferrule has to rest on solid tooth structure. So if you think it is weakened by caries or weakened by cracks, it doesn't really help out, because that is just going to fracture when it is subject to mastication. And it should never invade the attachment apparatus. So you have to respect the biologic width of the tooth. Okay. So now coming to the preparation of the coronal tooth structure, this is this will be taught to you in the Department of Prosthetics, like how you are supposed to, what kind of margins you are supposed to be giving. So generally we prefer to give a shoulder on the labial side for aesthetic reasons, and we give a chamfer on the lingual or the palatal sides because we require a minimal depth, a minimal width just to support the metal. So we prefer to give shoulders only on the labial and maybe on the proximal surfaces facing the lip or the cheeks. So just for enhanced aesthetics. Of course, we have to remove all the undercuts, which will, especially when you are dealing with your cast post and core, because if you are taking an impression and there is an undercut, your impression will tear or it will separate, because of which you will not be able to record a proper image. And you remove all unsupported tooth structure, that is undermined tooth structure, because you do not want it to fracture when subject to occlusal stresses. But you also have to keep in mind that you have to preserve as much of the crown as possible, so that your core can actually be retained on normal tooth structure. Okay, so the shoulder, this is what I was talking about. And yes, we tend to eliminate all sharp angles and establish smooth finish lines, because if you have sharp angles in your preparation, they act as stress concentration areas, which can tend to cause mini fractures in those areas. So this is the diagrammatic representation of how you actually create a custom made post. So as you can see in the second figure, you actually have the dedicated post pins, which on which the impression can be using which the impression of the canal can be made. So this is the direct technique. So basically what the operator is doing is he is just coating a layer of acrylic, or you can use your inlay wax to actually coat the pin, introduce it into the canal after your post paste preparation has been done. So and then you wait for it to set. So once it has set, when you remove the pin, so then you will be able to see that the canal has been recorded. Of course, before you introduce the resin or the inlay wax into the canal, we apply a layer of separating media so that it does not stick by any chance in the tooth structure. So after the pattern has been made, believe me, it's easier said than done, because you may have to do it in 1 or 2 attempts. After the pattern is fine and you're able to place it into the canal 1 or 2 times and see that it is fitting comfortably and it is going till the desired length, then what you do is you start fabricating the core buildup, of course using the same inlay wax, or in this case the operator has used resin. And once it is done, you are free to actually remove the pattern. Of course, in the fifth figure you also have to shear off the handle, so that you can actually fabricate your core buildup to mimic the crown, and then you proceed with your tooth preparation to receive the prosthesis. And as you can see in the seventh figure, you can actually see a nice ferrule on the labial and the proximal aspects. You can actually see that the core is sitting on a ferrule, and you can see that the crown margin or the tooth prep margin is significantly lower than the ferrule. So this aids in the retention of your crowns. Coming to your prefabricated posts, you don't actually have to struggle so much. And basically the prefabricated posts, the advantage is that you can actually, although we do not recommend it, but in cases where there is absolutely no chance of giving a ferrule, you can actually make do without the ferrule also, because the prefabricated post and core acts as one unit. It actually bonds to the restoration. The restoration actually bonds to the tooth, so the retention is significantly higher. You don't need a luting agent to lute your custom made cast post into the canal. So generally for luting the custom made cast post, we prefer using our type 1 GIC. It is, or you can even it used to be used, but it's no longer used. We could have used zinc phosphate cement also, but nowadays we prefer to use type 1 glass ionomer cement. Now coming to the prefabricated posts, before you lute it, you can use your resin cements, you can use resin modified GIC, you can even use normal GIC also. But we prefer to use the resin cements because it actually bonds to the post, and it forms one full unit, and this post and cement actually bonds to the tooth surface as well. So the entire tooth, post and core becomes one single unit, so the chances of retention are significantly higher. So before you lute the cement onto the into the root canal, you basically have to first, in the first figure you can see that they are checking the fit of the post into the canal, whether it's going into the desired length, that means the length till which you have prepared the post space. In the second step, they are actually etching the canal, because this actually helps to increase the retention. You are doing nothing but increasing the surface area of your root canal. In the third step, you actually place the post in, and there are two ways. You can either fill the root canal space with your luting agent, that is your resin luting agent, or you can coat the post with the resin luting agent and introduce it into the canal. So make sure that if you are using the first technique, that is when you are filling the like in the third figure you can see that they are actually filling the root canal with the luting agent. You do not shake the bottle, you do not shake the syringe too much, and you gently ascend outwards. That means you start from the innermost part, and then you slowly extrude the syringe into the canal. This is to avoid any air bubbles which can be entrapped when you are actually introducing the luting agent into the canal, and then you quickly introduce the post into the canal. And the second technique, of course, is you actually dispense the luting agent onto the mixing pad. You coat the post nicely with the luting agent, and then you introduce it into the canal, and then you have to subject it to curing. So once this has been cured, the post has actually been luted into the canal. So there are two schools of thought on when you are supposed to cut the or shear off the excess height of the post. The first theory is that you shear off before luting the post into the canal, because studies have shown that if you shear off the post using your drills after luting it into the canal, because of the forces which are used by the burr, you can actually transmit micro cracks into the region of the luting agent, because of which the retention is significantly weakened. The second school of thought says that it doesn't make much of a difference, so after luting you can actually shear off. So the major drawback of shearing off the excess post space before luting is that you do not actually have a clear picture on how much of a core buildup you actually want to do. So the reason being that it becomes difficult for us to imagine. You have to use the adjacent teeth for referral. So in those cases it becomes a little difficult. So what we tend to do is we actually do the core buildup, and then we shear off the excess post length. But then of course the chances of micro cracks running throughout the apparatus are significantly higher. And there, of course, you can see in the sixth figure, the core buildup has been significantly done, and then you do the final tooth preparation to receive the crown, and then you take the impressions, and in the last step you can see the prosthesis has been luted for the patient. So you can see a very good prosthesis which has been luted. And so basically this is the fundamental of your post and core. So if you have a badly broken down tooth, you have to assess whether you are going to be giving a custom made cast post, or whether you are going to be giving a prefabricated post. Prefabricated, again, do you want to give an active post or do you want to give a passive post? In this photo they have actually shown what seems to me to be an active post, which we no longer give because it actually does more harm than good. So we prefer to give the passive post. And when it comes to your posterior teeth, we of course tend to give the post in the widest canal. So in this case it's a mandibular molar, so we want to give it in the distal canal. So we prepare the post space, and if you see that the tooth has been broken down below the gum line, we can think of doing crown lengthening, that is the either using lasers, or you can use the ablation machine to give maybe 1 or 2 more of clearance, so that the post and core can actually sit on healthy tooth structure. And then you have significantly higher space, more space, greater space to actually prepare your tooth for the margins to receive your crown. And then so then you see the post placement is done, you do the core build-up. Try to give the ferrule on as many surfaces as you can. It helps to increase the retention of the post and core unit in the tooth. And then of course you give your final processes. So this was in brief about your post endodontic restorations. If you have any doubts, please feel free to contact me. I am always there to help and guide you guys. And I guess that's about it from my side. So stay safe, guys. Bye bye.